Well, thank you. It's my pleasure to present this webinar sponsored by Sakura FineTech. And I have worked in a hospital laboratory since the 70s, taking 2 years out to become a path assistant. And during my career, I've been able to utilize my clinical pathology and anatomic pathology in a medical university, a private pathology group that did forensic cases. And for the last 25 years, I've been in Des Moines, Iowa at a medical center that's really a mixture of my favorite things that I've done over my career. So what I'd like to share with you today is you make the diagnoses. Working in the laboratory, you say, well, why did I pick such a topic? Well, actually, we do make the diagnoses. We provide the dots, and I like to use analogies and diagrams and examples where I can. But really, if you think about going to, maybe a restaurant or something, and they hand you the kids' menu, you see all the little dots, and you go from 1 to 2 to 3 to 4 and make the picture. Well, that's what we've always done in our career. We provide those dots and allow our pathologists and our clinicians and our clinical care team to really connect those dots and come up with the diagnoses. So I applaud all of you who are listening and know that I'm talking to the best of the best because you're very interested in learning more and promoting continuing education. So my objectives today is just to share a couple neuropathology case studies, both forensic and hospital-based cases, explain what is called, and I mistakenly put TMN, but it's actually TNM, and I'll explain that to you, and why is there an excitement for a new version of that. Also discuss the lab team, how we really do offer an amazing profession, and I must say, for me, every day is exciting and new, so I hope you have the same enthusiasm with that. Also, what do we have to offer students? I know we're all scrambling to get students and qualified people to work in the laboratory. And then lastly, I want to talk about a topic that maybe some of you have already heard about, and something that's in the bright part of our future called precision medicine. So over the next 50 minutes, I'm going to share these cases and some of the material, probably bore you with maybe too many examples, but at the end, I'll be more than happy to answer your questions. And hopefully, if you learn nothing during the webinar, know that even after 41 years, I'm still excited to call myself both a medical technologist, and I'll use that interchangeably with a MLS or a CLS, as well as a pathologist assistant or a PA. So forgive me if I use that in acronyms, and don't hesitate to ask what I'm really saying. Let's start with some interesting neuropathology cases then. Most of you may or may not know about CT scans, and I'll try to point out some of the abnormalities as well as normalities when I have examples of both. Each of my cases, and I'm presenting 4 neuropathology cases just to kind of get you into what you're really excited about and what you really like in your career, is to correlate what you test is what I see, and that's what I've done with these examples. So I'm going to show you cases that will either be an aneurysm, a gunshot wound, trauma, tumor, or other, and that's represented in 4 cases. So the first case, whenever you see a diagram, you know that somebody outside of the hospital has been involved. This is our county drawing from one of our scene investigators, and you can see, and I'll use the arrow when I can so that I can show you what I'm talking about. We have a pickup truck that's on the wrong side of a road. This happens to be a gravel road. Left the road at a high speed, went through a culvert here and started to flip and roll. And the victim, which was the driver, actually got thrown out of the vehicle, and then the pickup truck came to rest correct side up toward a fence line. And so we got the actual victim. And the question is, okay, does this represent a hospital autopsy or does this represent a forensic autopsy? The difference between the two is really that in a forensic autopsy, we talk about manner of death, and everybody hears the word cause of death, but when you're really talking about manner, there's really only 5 categories. In a hospital setting, we usually only do cases that are called the natural manner of death. The people who died of old age, maybe congenital anomalies, those types of things, and their end of their life is really a natural manner. When we're talking about forensic cases, those are anything that are considered not natural manners, and so that would be homicides that you read about in the newspaper, suicides, accidents, and then undetermined. And to put the an undetermined manner of death on a death certificate does require a forensic pathologist. So when we talk about normal neuroanatomy, these are both adult brains. On the left, you can see the base at the bottom of the brain, and you can see these are the olfactory bulbs, and then here's the vessels, which we know are the internal carotid arteries. This is a basilar artery, and this is very normal. So we see the gyri, which are these ridges, and the spaces in between, which are the sulci. When we cut the brain, and we can cut the brain many different ways, we recognize that there's gray matter in the cortex, differentiated with the white matter. We have the ventricles in the center. And then we have, in this particular coronal section of the brain, we actually see the nerves that go to the eyes, which are the optic nerves. So this is all normal, both the bottom of the brain. The structure here is actually called the cerebellum, and if you really look carefully, this is the spinal cord. So this is where the spinal cord has been amputated, and of course, in this section, we don't see that. This little red dot you see here is just a vessel. That just is a little bit more prominent, but again, this is all very normal. So now let's talk about case one, that gentleman who left the road, got thrown out of his car, and what we saw in autopsy. I have a couple examples here of this same type of scenario. This particular person had a lot of blood surrounding their brain, and this is called subarachnoid and subdural hemorrhage. All this blood here is abnormal, obviously. When we look at a little bit closer up on this particular brain, we notice that there's an aneurysm here, and we have a probe inside the aneurysm. This would be a middle cerebral artery aneurysm. There are aneurysms that occur in other places in the brain. This is a different case, which is called the cerebral arteries, and this actually is a circle, and so many of you remember your anatomy where they call this the circle of Willis, and that's why people, if they get a thrombosis or a blockage of one vessel, it goes in a circle and re-establishes blood flow, and that's why symptoms of maybe paralysis or memory loss or something along those lines get reinstated, because you get that circle. Well, when you have an aneurysm out here, sometimes we don't have that circulation reestablished, and so people do maintain their deficits. But let's go back to this case that we're talking about. And so in this case, we actually have an aneurysm, and I'll give you that. Now, again, a few more examples, different brains that I just want to kind of share my point with you. Not only do we get blood that goes outside the brain in a subdural or subarachnoid manner, but we also get sometimes some very significant changes of the brain, and this happens to go with this. And what happens is, because the brain is in a very solid area, our skull, the brain, especially if the person's in movement, will hit against the skull, and then we get changes of the actual brain tissue, which is a contusion. Now, you've heard about the contusions that our athletes are getting, and they find out over time many contusions lead to kind of a dementia. And so some of these contusions that we're talking about do heal, and so we never obviously see these patients at autopsy. But in this particular patient, and the point that I want to make with this case, is this aneurysm actually ruptured into the brain. And so this person really did not have an accidental death, but actually the manner of death was actually natural, and that was due to a ruptured cerebral artery that led to a bleed into the brain, caused immediate death or passing out, and of course left the road, and that's the answer for this case one. Case number two, we notice that the brain is cut a little bit more along that coronal section that I showed you before in the normal picture. This happens to be everything on your left is the brain left, everything on your right is the brain right. Here in the left frontal portion, there's some redness, and I know this isn't the best picture because of the black background, but there's quite a bit of destruction here in this left frontal area. You can see more destruction here, starting to be some destruction here in the medial aspect of the right cerebral hemisphere. And as we go down into the sections that I've shown here, you can kind of appreciate that the destruction is pretty significant here in the left frontal and gets a little bit less, however, it goes from left to right in the mid portion of the brain. And this particular case had a lot of skull fractures, and we've actually moved some of the skull fragments from this to show you how destroyed the brain was. And of course you can see the arrow. This is the kind of the midline of the skull here. So this is the left side, this is the right side. Quite a significant amount of damage to the brain, as you saw more in the fixed state. These are skull fractures before we've removed some of those plates. So here's your multiple choices: aneurysm, gunshot wound, trauma, tumor, or other. And this, again, we're going to show you some normal. This is a CT scan where we're looking from the bottom toward heaven. So this is the left, this is the right. This is that cerebellum that I showed you before. This is the brain stem called the pons, and you can see the nasal septum with the eye sockets. This is the brain on a lateral view, so you're seeing the brain, how it connects with the spinal cord. And so when we use ballistic gel, this really points out how destructive an entrance wound can be, or a ballistic wound, usually from a rifle or even a shotgun, can really create a very significant cavity here. And what I want to point out to you is if we use the same CT scan that we had from the specimen I showed you, the pattern goes from left upper or left frontal down to the the right parietal. And so this is how I've turned this ballistics to show you a great big cavity was created in this example, and that's why there's so much destruction that occurred from the left frontal down into the right medial aspect of the brain. So I'm sure now you know the answer, and this is indeed an example from case 2 of a gunshot wound. Case 3. Now this, I'm telling you, and you've already seen, is an example of an intracerebral hemorrhage. This is the cerebrum. This is the right portion of the cerebrum. This is the left, and you can see there is well-differentiated gray and white matter here. You can also appreciate that there's something very striking and abnormal here that goes all the way to the cortex. So what's our choices here? What is the choice? And this is really what happened to this unfortunate person. These are the examples of their sections in a coronal fashion, that this person actually had a brain tumor. And so the biopsy that was performed went through the dura, or the covering membrane, over the top of the right side of the cerebral cortex, and really there was destruction, and they removed some of the tumor. However, there was a bleed, and it led to this person's demise. So this intracerebral hemorrhage is actually secondary to intracranial brain biopsy. And so in this case, this is an example of tumor. Now this is case 4, and this is the last of my neuropathology cases. And this is obviously different than the coronal sections I showed you before, because this is a baby brain, and this happens to be a baby brain that's premature. We don't have much of a gray and white matter differentiation. We do see the ventricles here that have been compressed. We do see some changes here, and this is intracerebral hemorrhage. So again, our multiple choices are, and this happens to be the premature infant that this brain was removed from. And so what we actually have here is we have interventricular. You don't appreciate the interventricular hemorrhage in this picture that I've shown you, but we do have intracerebral hemorrhage in a premature infant. And just the nature of a premature infant plus the trauma sometimes of delivery can indeed lead to the bleed. So we have the trauma as well as the other, meaning the premature nature of what happens. Now what's also interesting, and many of you may already know this, is that in intracranial hemorrhages, we actually grade these so that it isn't always catastrophic or leads to death, but actually hemorrhage can be in babies, even in premature babies, that do not lead to death. And the ones go from grade 1, which is the least severe, to the grade 4, which is the most severe, and an example of what I shared with you. There are many different variations, and just to grade it in 1 through 4 is very helpful, not only by ultrasound, but also when we do an autopsy to confirm those findings by either prenatal or perinatal ultrasounds, or when we do an autopsy just for good correlation. And that's what we're supposed to do with the healthcare team. Teach us all how we can get better at what we do. And this is what it looks like under the microscope. So we have a H&E, which shows a very significant hemorrhage and destruction of the cerebral white matter, and even I think if you looked at this under maybe a little bit higher magnification, you would see that this is all blood and red blood cells that have gone into the parenchyma of the cerebrum. Now let's switch to a different topic that I want to share with you, and this is the TNM staging system. And in essence, in a very simplistic form, TNM, T stands for tumor, N stands for nodes, M stands for metastases, and what we're trying to do, these are for malignant cancer staging, is to take apples and compare apples to apples. So by separating out the different kinds of apples into categories, be it a lung cancer or a breast cancer, a colon cancer, and utilizing a system for each of those kinds of cancers, we can do meaningful and share meaningful information. And that's one of the big goals that we have in anatomic pathology when we're on the surgical bench, is receiving malignancies and making sure that we give the information so that the TNM staging system can be used. And here's what I said. The T stands for tumor, N stands for nodes, lymph nodes, and usually regional lymph nodes, and M stands for metastases. And I'm proud to say that the pathologist assistants have been asked to assist with the new staging manual, which has just come out in May. And you will, if you do work in an area where you do grossing or where you do recognize the staging system, that there will be many diagrams and much, much more information. Let's just use lung cancer as an example of where TNM comes in. Since lung cancer deaths are the most common deaths for both males and females in the United States, I thought that would be a good topic to use. 85% of lung cancers are non-small cell. They spread more slowly, but the 15% that you hear about are the small cells that spread very rapidly. And these are some examples where cigarette smoking for the small cells is one of the major risk factors. And we'll show you that the architecture of the lung starts with very delicate alveoli. These are capillaries with spaces that are where the oxygen gets exchanged from carbon dioxide, which gets moved into the blood, and oxygen that goes from the capillaries out into these excuse me, I said that backwards, where oxygen from the alveolar spaces gets pulled into the capillaries to go to the rest of the body, and then the capillaries release the CO2, which then gets breathed out. And then this is an example of a very significant small cell cancer that has spread significantly throughout the lung. So here's an example. We have a right middle lobe. This is the measurement of that lobe of lung. There's a 1.2 centimeter nodular mass that gives a distance from the closest staple line without pleural involvement, and this staple line represents a margin. There's some additional possible nodules in this lobe of lung, and both the bronchial and vascular margins are unremarkable. And then we also, in that TNM, we want to look for lymph nodes. So in the specimen, there were some regional lymph nodes that are up to 1.3 centimeters of maximum dimension. So the micro shows that the pleural margin is involved by invasive tumor. Those separate nodules that I mentioned are indeed tumor nodules, and 1 of 4 lymph nodes were positive for tumor. So what does that mean? How do we compare the apples to apples here? Well, this is the version, the 7th edition version of that TNM staging. So we go down here and we have 1.2, so we'd expect it to be, maybe a 1A. But now that we're talking about additional separate nodules, this takes that to a T3. So we also can use that if we look at an MRI or CT. We have a little acronym with a C, which stands for clinical, or when we actually get the resection specimen, we use the P. So even in a patient's chart, if they've had surgery, you'll see a TNM, which has a P, or if they've only had scans and a workup, you'll see a C after that. And this is actually the cover that you may see in your laboratory for the 7th edition. And as I mentioned, because there's additional nodules, that makes it a T3. Because of the positivity of a lymph node, we now have a PT3 N1MX, and the X stands for we don't have any other tissue received with the specimen to denote if there were or were not metastases. And this is how we compare all tumors, all malignancies. And I want to give a little bit of a plug here about the 8th edition, and for those of you who work with the manual, you can be sure to be ready for this. What has been 628 pages is now more than 1,100 pages. There's going to be better diagrams. There's going to be additional studies in these worksheets, and these are called the synoptic reports that you see in a patient's chart or that are floating around in your department. Not only gene rearrangements, biomarkers, mutation analysis, and it's going to go on. And all of this is really going to equate to better prognostic information. Also, as we all know, computers are the item that we use as our daily repertoire, and so having computer-friendly approach is very, very important. So again, if we were to use the 8th edition, not only would we have what I shared before, but now we would be incorporating these additional markers with information for the clinician, as well as sharing prognosis with the patient. And this is just an example of some of those biomarkers that we're going to be talking about: TTF, P63, CK56, and it goes on and on and on. And I'm sure over the course of the future, it's going to even grow more. Let's again shift to a different topic. Who is the lab team? Why are we so important? And as you know, it's incredibly difficult to get individuals who want to even consider going into the laboratory field. We usually think about histotechnologists, cytotechnologists, clinical laboratory scientists, laboratory assistants, pathologists, pathologist assistants, and of course we have very important administrative and clerical staff on our team. And we do offer, and I just can't state this enough, how bright our future is in histology. And for those of you who work in the clinical side, also on the clinical pathology side. In fact, in the Department of Labor Statistics, which I know these are old, but it's just amazing where development needs to go, that we are just really on the cusp of providing entry-level professionals, and how we need to share what the entry level goes to with this new staging manual, with the utilization of gene markers and rearrangements and all the work that goes into helping patients. There's just a wonderful, wonderful future for all of us. And we also need to recognize that specialization that all of us love. When we start out, sure, we're entry level, we're generalists, but over time we start to gravitate toward a specialization that only we provide, and that's really exciting. For careers in the laboratory, I don't know if you have your laboratory divided the way ours is, but in just a generalistic point of view, the lab administration is usually the medical directors, the pathologists, there's staff pathologists underneath the head pathologist, and then of course we have an executive director who oversees everything. In our particular laboratory, about 5% of all of our volume is anatomic pathology, and actually it's decreased, and I'll explain to you in another diagram in just a second. The other 95% of the clinical pathology. In fact, as a med tech, I always used to say, what I test is now what I get to see, and that's very exciting for me since I'm a visual learner and love the idea of diagrams and learning that way. Let me just backstep here for a minute definition-wise. Accreditation. Accreditations and sometimes certification and licensure may be used interchangeably, but they really are very different entities. So if we want to be professionals in our career, we also need to understand these definitions. Accreditation, we're talking about training programs, educational requirements, things that are incredibly important for us to gain our credentials. In other words, we have to have gone through an accredited program in order to be recognized as what we are, professionals. Certification, and that's for the profession. That's what we take in order to show our credentials as meeting the entry-level qualifications, and then later on, if we do specialize, to show that qualification as a specialist. And then licensure, I know that there are states, Texas, California, Florida, I'm sure I'm missing Louisiana seems to come to mind as well, that now that there are state licensures for professionals. And the most common that we recognized. Both our pathologists are state licensed, as well as RNs, and there's registered therapists in occupation, in physical therapy, and I know the list goes on and on. But what future do we really have to offer? Well, as I mentioned already, probably more than you wanted to hear, how many new histopathologic techniques are on the horizon. And all of these are very important for not only cancer treatments, but either other things that we talk about. Even medications. We even do assays to determine if medications will work on different people. We also want to improve our turnaround times. Even the selection of the tests that we do, the equipment, all of the equipment that companies like Sakura are producing, the modifications of equipment, our expertise about utilizing this equipment is incredibly important. And nobody is better qualified not only to maintain this equipment, but also do quality assurance, as well as troubleshoot this equipment than we are. The clinical pathologic experience, and I got to tell you, this is just amazing to me. Even today when I did an autopsy, I just realized that there was something that I found, and the clinician, the head clinician, didn't even recognize that that was going on with the patient. Here we are doing clinical pathologic experiences that we can correlate and really give diagnostic information to our clinicians and the entire healthcare team. And like all of you are participating today, the CME opportunities. We're not only improving what we can learn, but also what's out there and sharing that information. And to me, that's really exciting. And then you've heard that term artificial intelligence, which God only knows what that's going to be tomorrow, let alone in the next year or two. And this is a little bit more broad of what goes on in anatomic pathology. I've already mentioned the anatomic pathologists. In our hospital, about 3% of our total volume, and we're at about 5 million tests a year now, is performed in surgical pathology or histopathology, cytopathology, and autopsy pathology. And these are the individuals who work in those areas. When we talk about clinical pathology, of that 5 million tests that I mentioned, obviously the vast majority are in clinical pathology, and these are the hierarchies in those particular areas. And we're just now talking about new and other exciting areas in the laboratory, in molecular biology with PCR technology, the research and development, even phlebotomy and point of care testing. I mean, it's just amazing to me where we're going and where we can go. So let's quickly talk about the shortages that we already know about in the laboratory. I just did this internet search, maybe 2 weeks ago when I was invited to give this webinar, and here we go, and we put in careers in medical laboratory, 1.5 million hits, and that's just nothing. When we're talking about salaries, a broad range of salaries, the shortages. Well, in the state I live in, Iowa, we're about 3 million for our total population. And here we are talking about shortages, which is our entire population of our state. And as you know, that's only going to grow in the next 20 years. In fact, some estimates were that it's going to grow almost 15% in that gap of 2010 through 2020. We know our population is growing. We already mentioned the growth in technology. And more importantly, our population is aging. So the question is, who's going to do the work? Who's going to take over these responsibilities when we leave or go on and retire? And these are just a listing of the 20 board of certification that are provided through ASCP and ASCP. And as you know, the board of certification are completely different, but these are the 20 that are listed. So here is just 20 groups of individuals that we currently recognize, and I'm sure in the very near future there's going to be many, many more who are recognized and going to be needed within just our laboratory, let alone healthcare in general. Again, dividing them up into technicians, technologists, specialists. I mean, it's many different ways that we can recognize where we need to go and what we need to consider as we look in the future. And as a histotechnologist, even the idea of an education and more formalized education is just really not that old. For the PA education paradigm, I just wanted to share, this is what I started out with, a broad didactic education. They taught me all these different things, but here it is, for me 30 years later, all these future skills that I can't even begin to list. And it's just a very, very important part of where we're going and what we need to consider as ambassadors to our profession. Let's talk about precision medicine. If you don't think this is a real entity, who would have thought, or I couldn't have thought 41 years ago, that I'd be sitting on a phone in front of a computer talking to many people throughout the United States and maybe even outside of the United States about technology and how we can utilize the memory that we have access to. And that's what precision medicine is. In fact, a wonderful speaker that I got to meet, Carolyn Compton, is actually a former chairman at Mass General Hospital and is now actually given a title. She is the director of the Complex Adaptive Systems Institute of Arizona State University and Mayo Clinic College of Medicine. And in other words, what she is she's the brainstormer. And she shared with me this slide that we talk about gigabytes. You know, most of us have a hard drive at our home computer that may be 1, 2, 3 gigabytes. Well, now, as you know, we have terabytes. And we take 1 terabyte, that's how many songs that are in 1 terabyte. You take 235 terabytes, and that's the entire contents of the Library of Congress. Even our cell phones, look at that. It goes from 16. Now, how many of us have really 16 gigabyte cell phones? It's now, many of us have 64, and I'm sure very soon we're going to see even greater than 64 gigabytes. And then we go to gigabytes and terabytes and petabytes. And look at, now they even have a zettabyte. And all of these things are what we're talking about when we talk about the amount of memory that's accessible to us. And why is this important? Why is it that we are going to have utilization, and why do we need this memory in front of us? Well, again, when we talk about precision medicine, what does that mean? What are we going to do with this? Well, first of all, we have LIS, Laboratory Information System. We have electronic medical records. We've got all this information in there. How can we utilize this? Well, we can utilize it in the procedures that we do, the interventions that we do, pharmaceutical research, statistics, special diagnostic techniques, biomarkers, genetic testing, clinical pathology test results, anatomic pathology test results. For some reason, we don't do that many autopsies, but when we do utilize autopsies, we got that data, and we've got all this future, all this diagnostic and cost-effective opportunities that we can all incorporate into our precision medicine and utilize this data because we have the memory and the storage devices that will get that to us almost in an instantaneous basis. It kind of reminds me of the Pasteur scientific theory. If you remember, and you're as old as I am, you remember back in the day, we learned about this where there was a purpose. What do you want to learn? The research is find out as much as you can, a hypothesis of try to predict the answer to the problem, or in other words, an educated guess, design an experiment that will confirm or disprove your hypothesis, and analyze this, and then come to a conclusion. And that's exactly what precision medicine is going to be. Help us utilize all of these old scientific theories to come up with better and faster conclusions that really make an impact on our patients. Here's an example of where I kind of put this through and what has transpired. Oh, back in, I think this was 2010, we had an issue where we did have a death of an individual who died of Legionnaire's disease. Just taking what we knew about where Legionnaire's disease came, and if you remember the history of Legionnaire's disease back in Philadelphia, we came up with a patient information form and what we could share with our patients about how to take care of themselves and how that they would not be afraid of getting Legionnaire's disease by coming to our hospital. That's a simple example of precision medicine. Here's another example. Here we've got a mass. We've got an individual has a mass. We talk about the chest margins, and this is just what we use today in histology. And here we go. We've got different markers that we can use. We can help the patient. We can help the oncologist just by incorporating these markers in the diagnosis and helping the family and maybe even future generations with how to avoid getting this poorly differentiated cancer. And we take strokes, just something as simple as strokes. Sure, we know what strokes are caused from. We know how we look at a section under the microscope and what it looks like. But how about all of these risk factors? How about the patient? What about those risk factors that do they have these? Do they not have these? How about are there race and ethnicities that we can include? Of course, we talk about smoking and heart disease and diabetes. So many other things that we can incorporate in our precision medicine. And lastly, I'll end with some references if you're interested in pursuing some more, or maybe you're interested in becoming more specialized in what you do. Here are some websites that you're more than welcome to utilize. And lastly, I want to share with you a misnomer that a lot of people use. Sometimes they Google things and they don't realize that the information that they're gaining is may not be as accurate or as useful as what they expect. But really, you should never have to buy or donate for any information, and be cognizant of where your information is coming from as well as where you're using that. I know our high school students and even younger sometimes take Google as a gospel, but always keep in mind where that information is being utilized as well as the studies that it comes from. I think that's pretty much all I have. I know this is probably a little bit quicker webinar than you were maybe expecting, but I just know that that's a lot of material. And if you have any questions, by all means, please don't hesitate to ask them. If you need or are interested in contacting me, by all means, please do. I welcome any coworkers as well as anybody who's interested in sharing your expertise with me, which I always appreciate.